Assalamu alaikum and good evening to you all. Welcome to another medical educational program by SCP Bangladesh chapter. We call it Health Talk on Acute Medicine, organized by SCP Bangladesh chapter and supported by Bangladesh Society of Medicine. Today is the fourth episode of our acute medicine series. On this episode, we are going to talk about one of the most concerned emergency in medical science. Today's topic is the diagnosis and management of the life-threatening emergency, sepsis. To talk about this important topic, we have one of the most prominent and potential physician of our country. He is famous for his excellent clinical skills. He is none other than Professor MD Titu Miah sir. He is the principal and professor of medicine, Dhaka Medical College. He is also the former Secretary General of Bangladesh Society of Medicine. To chair the session, we have the legend of the legends, the person who needs no description, the true genius and magician of internal medicine, Professor Quazi Tarikul Islam sir. He is the founder governor of SCP Bangladesh chapter and also the former president of Bangladesh Society of Medicine. As the panelist, we have the two most renowned professors of our country. Firstly, the person with a strong personality and talent, Professor Major Retired MD Julshash Uddin sir. He is the professor of medicine, Mars Medical College. We also have one of the most skilled professors of our country, Professor H M Feroz sir. He is the professor of medicine, Munnu Medical College. As a moderator, we have the talented and beautiful Dr. Nawsabah Noor. She is the Registrar of Medicine, Popular Medical College. During this live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Nawsabah Noor. Dr. Nawsabah Noor Apu.
Thank you, Dr. Prince, for your brief and beautiful introduction. Assalamu alaikum and good evening, Honorable Chairperson, respected teacher, panel of experts, speaker, and ladies and gentlemen. On behalf of American College of Physicians Bangladesh chapter, I would like to welcome you all to tonight's session. Tonight, we are going to discuss on a very important topic, diagnosis and management of emergency, that is sepsis. As we all know that sepsis is considered is the medical emergency, and physicians from all levels should have a clear and complete idea of the sepsis regarding the diagnosis and the management. When we deal a patient with sepsis, we are actually dealing with a ticking bomb, and every hour's delay in the management actually increases the rate of mortality. And all around the world, around 85% sepsis-related death occurs in the low and middle socioeconomic country. So as a physician of our Bangladesh, so we have to have a very good knowledge about the sepsis. And to speak on this very important topic, we have a very famous speakers and very popular mentor and teacher, none other than Professor MD Titu Miah sir. And in the panel of experts, we have another two legendary professor, Professor Major Retired Mohammad Julshash Uddin sir, and another legend is Professor H M Feroz sir. Sorry about that. And to chair this scientific seminar, we have another legendary professor. He is actually the example of him being himself, that is Professor Quazi Tarikul Islam sir. So without any further delay, I would like to welcome Titu Miah sir to start the session. Sir.
Am I audible? Am I audible, Noor?
Yes, sir. Yes, sir.
Thank you for nice introduction to Dr. Nawsabah Noor and also the Prince. And today, my mentor, the chairperson, Professor Quazi Tarikul Islam sir, and my another mentors and big brothers, our honorable colleagues as a panelist, Professor Julshash Uddin sir and Professor Feroz sir, and honorable participants. On behalf of SCP Bangladesh chapter, for selecting me as a speaker of the topic, which is very much important clinically and in the in the diagnosis and management aspects in our day-to-day practice, which has already very nicely introduced by Professor Nawsabah, Dr. Nawsabah, and I'm going to start my presentation with the permission of Honorable Chair and Panelist. So we have already have been encountered what is the burden of the sepsis. And a few years back, the sepsis was causing about the 6% of the total mortality in the mortality certificate. This is data is collected from the death certificates all over the world. And very recently, it has improved its position in terms of causing the mortality. You look at the slide, the severe sepsis is the top scorer among the number of the deaths caused by different diseases like this acute myocardial infarction, lung cancer, colon cancer, and breast cancer. And severe sepsis is one of the topmost cause of the death in the whole over the world nowadays. 48.9 million cases and 11 million deaths occurs, and 1 in every 5 deaths worldwide are associated with sepsis. 85% occurs in the low or middle income countries. 2 out of every 5 cases are in children under 5. So in Bangladesh, very limited data are available. This is collected from spectrum of the severe sepsis in critically ill adult patients of Bangladesh, a prospective observational study by Ahmad and others, which was published in September 2015. They have found 95 out of 228 patients, total admission in 7 months from an ICU in Dhaka, are suffering from sepsis, around 41%, and 58% of this study populations were in septic shock. So look at the number of the cases in the ICU and the contributing of these 228 numbers, 41% from sepsis and 58% has developed septic shock. So sepsis is common and often very much deadly, and it remains the primary cause of death from infection, especially if not recognized, treated promptly despite modern medicine. Septic shock hospital mortality is in excess of 40%, and in some countries, even in USA and UK, some data shows, some publication shows this, it is up to the 50%. And that very mortality, especially in ICU patient due to sepsis, was about the 40 to 50%, and it is near about 70 to 20% in non-ICU patients, those who are not in the ICU but diagnosed as sepsis. If we look at this curve, 1 year survival among the 87,580 patients after sepsis discharged to home. It indicates the mortality is very much within a short span of time, and those who survive for longer duration, the mortality gradually declines. So life-threatening organ dysfunction caused by a dysregulated host response to infection is called sepsis. Septic shock is a subset of sepsis in which underlying circulatory and the cellular metabolic abnormalities are profound enough to substantially increase the mortality. And this definition reflects the most up-to-date scientific evidence available, but they are not specially useful clinically. So sepsis in very recently it is defined as the organ dysfunction can be identified as an acute change in total SOFA score of more than 2 points consequent to the infections. And septic shock, a sepsis with persisting hypotension requiring vasopressors to maintain the mean arterial pressure more than 65 millimeter of mercury and having a serum lactate level more than 2 millimole despite adequate volume resuscitations. And this is set from the third international consensus definitions of sepsis and septic shock, which is nowadays called the Sepsis 3, and published in 2016 February. So any unexplained acute organ dysfunction, when there is any unexplained acute organ dysfunction, should raise the possibility of underlying infection. So initially, it was thinking about which was very much interrelated: infection, sepsis, severe sepsis, and such, severe inflammatory response syndrome. Nowadays, in Sepsis 3, the severe sepsis has been omitted. Now, sepsis and septic shock, dysregulated host response, life-threatening organ dysfunction, and infections are intermingled and related to each other. What are the primary sources of severe sepsis in different studies? Just please look at this slide. In different countries, we have gone through a collection of some data, and we have found pneumonia is about around the 70% cause of the patients suffering from the sepsis. Leading to the contributing cause is the pneumonia. And if we go through in different countries, it is around 65% in Brazil, in Asia, total 37%, and Spain it is 38%. And in Bangladesh, in 2013, it was 58.4%. So pneumonia is increasing in number nowadays. And UTI is almost the similar percentage, but in 2013, there's a part of the Eurosepsis, it was 20%. And abdominal sepsis, the source of infection, primary source in the abdomen was 4.6% in our data. And in Bangladesh, 2013, it was 10%. And in Spain, it was 29%. So other source of infection like the soft tissue infections and skin infections, intravascular catheterization has been shown in the data. So pneumonia is one of the top scorer, and second important is the UTI, and third is the abdomen. And in this series, one of the important etiological factor is not clearly mentioned, is the number of the septic abortion cases contributing to the sepsis. So this is a slide of I want to show you the model of oxygen stress in sepsis, how sepsis is contributing in injury to the different component of the cells, including the mitochondria and other component of the cells, leading to the liberation of the cytokines and injury to the cells. So there are 6 components of the sepsis assessment. One is the respiratory assessment, which is mainly assessed by partial pressure of oxygen, the proportion between the partial pressure of oxygen and FiO2. The coagulation system, by counting the platelet, and hepatic function test, hepatic system, by assessing the bilirubin, and cardiovascular components, including the mean arterial pressure and vasopressor type and dose. And CNS component as assessed by the DCS score, and renal component is assessed by the serum creatinine or urine output. So in sequential or sepsis-related organ function assessment, what is called the SOFA, I have mentioned in the previous slide. This is the score 0 to 4. And the systems are mentioned like the respiratory system, what I have mentioned, respiratory component, coagulation, cardiovascular, and central nervous system, and renal. And the amount, like if the partial pressure of oxygen FiO2 is more than 400 or equal to 400, it is 0. And if it is less than 100, it is 4. And similarly, in platelet count, if it is more than or equal to 150, then the score is 0. And if it is less than 20, it is 4. And if it is less than 50, it is 3. Simultaneously, bilirubin amount, if it is less than 1.2 milligram per dl, then it is 0. And if it is more than 12, it is 4. Look at the cardiovascular component. mean arterial pressure is more than 70 or equal to 70 millimeter, it is 0. And if it is less than 70, it is 1. If we introduce dopamine less than 5 or dobutamine at any dose, then it is 2. And if the dopamine dose is 5.1 to 15, or epinephrine is less than 0.1, or norepinephrine less than 1, then the score is 3. And dopamine is if more than 15, or epinephrine more than 0.1, and norepinephrine more than 0.1, the score is 4. So this is the way how we can assess the SOFA score, and can say the more the the amount of the score, number of the score is more likely to have the mortality of the sepsis, and severe, it means indicates the severity of the sepsis. Q-SOFA suspect infections outside the ICU. This is a very quick assessment of the SOFA score, not assessing the biochemical aspects, rather it is assessed clinically at the bedside. So if the respiratory rate is more than 22 beats per minute, and there are 3 components: altered mental status and systolic blood pressure less than or equal to 100 millimeter mercury. These are the components. And if the Q-SOFA score is more than 2, we can suspect the possibilities of the infections or sepsis. May I request to look at the scenario. 4 days after abortion, we found patients febrile, disoriented, and blood pressure was 100/40 millimeter mercury with dark urine. And look at the hands of the patients. There are some ischemic changes, and serum lactate was more than 40 millimole. So there are some patients may present with septic abortion, presenting with DIC and other manifestations due to sepsis. So if we look at this scenario, young diabetic patients with septic arthritis, with high fever, with tachycardia, with respiratory rate 40 per minute, and blood pressure 110/50, and there are some gangrenous spots in the tip of the fingers, and also the lower limbs also. So this indicates the septic emboli. So in the nowadays, we are getting the patients of COVID-19. We are dealing with the pandemic, and most of the patients, most of the ICU beds are occupied by the COVID-19, and some of the patients are associated with, the the COVID-19 and sepsis are residing together in single patients. So sometimes there might be similarities in some components. There are some dissimilarities. So multiple organ dysfunction is both common in case of COVID-19 and also in the sepsis. So venous thromboembolism and arterial thrombosis occurs more frequently in COVID-19 induced coagulopathy compared to the non-SARS-CoV-2 induced coagulopathy. Immunosuppression, cytokine storms is a major problem in sepsis, while immunosuppression is the major problem in COVID-19. So both cytokine storms can happen in case of COVID-19, but immunosuppression is an important factor. DIC is not that much common in case of COVID-19, but very much encountered in case of sepsis. So sepsis is characterized by the systemic hypercoagulation and suppressed the fibrinolysis. While in severe COVID-19 induced coagulopathy, this is very much localized and local thrombosis occurs. The deep vein thrombosis is very much common and not a systemic involvement. And there is no diffuse involvement. So elevated bilirubin, hypoxemia, reduced glomerular filtration rate, and hyperbilirubinemia both can happen in case of SARS-CoV infection. But this can happen also in sepsis. But sepsis may not be a risk factor for the factor to the SARS-CoV. So SARS-CoV may be associated with the sepsis, but usually sepsis does not invite the SARS. The sepsis does not invite the association of the SARS-CoV. This is some information about the sepsis and COVID-19. Sepsis and COVID-19, sometimes it is very difficult to differentiate sometimes. But when COVID-19 is associated with sepsis, we used to find that total count is increases. We sometimes measures the procalcitonin and other things. And we used to treat the patients empirically, and we also used send up, the blood culture and other material for culture to find out the evidence of infections. But mostly we used to treat the patient simultaneously by suspecting clinically by the evidence of the neutrophilic leukocytosis and also the presence of raised, the procalcitonin level. And all the patients having severe SARS-CoV must be screened for the evidence of the sepsis or associated infections. And the patient should be reviewed over the 24 to 72 hours for the microbiological evidence of the presence of the infection in case of COVID-19 in severe cases. Regarding the best effective management of the hemodynamic support in case of COVID-19 patients with septic shock, these are recommendations. For adults, recommendation 1, for adults with COVID-19 and shock, it is suggested using norepinephrine as the first-line best effective agents over the other agents. This is a weak recommendation, low quality evidence. Recommendation 2, if norepinephrine is not available, it is suggested using either vasopressin or epinephrine as the first-line best effective agents over other best effective agents for adults with COVID-19 and shock. This is a weak recommendation and low quality evidence. Recommendation 3, for adults with COVID-19 and shock, it is recommended against the using of dopamine if norepinephrine is available. If norepinephrine is available, this is the strong recommendations and high quality evidence. So sepsis and septic shock are medical emergencies, and treatment and resuscitation should begin immediately, as it is a medical emergency. So early initiation of the treatment and resuscitation is a must. The vital part of the management is starting the antimicrobial therapy, and microbiological culture before starting the antimicrobial therapy must be done, both the aerobic and anaerobic. Cultures can be sterile within minutes to hours after the first dose of an appropriate antimicrobial. So judicious selection of the antimicrobials and starting as early as possible is very much effective in salvage of the patients, in resuscitation of the patients. IV broad-spectrum antibacterial as soon as possible after recognitions and within 1 hour of the within 1 hour the first dose should be started. Empiric broad-spectrum therapy with one or more of the antibacterials, especially the beta-lactams, should be included within these empiric antibiotics. And the antibiotics should be started as early as possible. And why this is empiric? Because even with all efforts, 50% of the sepsis is sterile, the culture negative. And delay in every hour, mortality increases 5 to 10%. So this is very, very important. So if we go for any delay, it may cause the mortality, 5 to 10% increase per hour. Antimicrobial treatment duration the duration should be 7 to 10 days. Shorter courses, particularly those with the rapid clinical resolution, the course should be short, 7 to 10 days. Longer courses in patients who have slow clinical response, undrainable foci of infection. So if there is focus of infections which could not be drained or which could not be removed, then the antimicrobial therapy should be prolonged. And there is bacteremia, especially with the Staphylo aureus, gram-positive organism. Invasive fungal infections and viral infections are there. And immunologic deficiency, if the patient is immunodeficient, including neutropenia, then the course of the antibiotic, duration of the antibiotic should be longer. Just this to see what is the extent of the the resistance of the organisms to the conventional antibiotics in our situations. This is from one of our ICU setup in our wards also. This is happening. Just look at the Escherichia coli is removed from the culture removed by culture, and look at the antibiotic. Almost all the antibiotics are resistant. With only the amoxicillin has got the intermediate sensitivity. there is no sensitivity to any other good antibiotic. So we are getting the more antibiotics, newer antibiotics, but we are also getting the more resistance, and very difficult to find the appropriate effective antibiotics nowadays. So this is the microorganism profile and the antimicrobial resistance pattern isolated from a lower respiratory tract of mechanically ventilated patients in an intensive care unit of a tertiary care hospital in Dhaka, which was published in 2019. And if we see the organism, like the Pseudomonas, separated from 4 blood samples was positive. In urine, it was in 14 patients, and tracheal secretion was 26 patients, and own swab was in 2% of the 2 patients. And the percentage indicates among the total cases, 56% of the cases was positive to Pseudomonas. Second, look at the Acinetobacter was removed from, found in tracheal secretion in the highest number. It is 60 in number, and 74% of the total cases was due to the Acinetobacter, which is almost resistance. We used to found almost most of the organism except colistin and polymyxin. And look at the Staphylococcus, the total number is 8% only, and Klebsiella is also found in insignificant number in this series. If you look at the resistance pattern, almost 100% of the Acinetobacter is raised to the piperacin, but it is 42% is resistance with piperacin is added with the Tazobactam. And Pseudomonas is about piperacin and Tazobactam resistance was 65%. Similarly, ceftriaxone, the inaberrant use of the ceftriaxone is causing these situations. For Acinetobacter, it is 90% cases, it is resistance, and 95% cases is Pseudomonas, and 71% in Klebsiella, and 85% of the sample for the E. coli was resistance to ceftriaxone. So the resistance of different antibiotics we have found. Most of the effective antibiotic or popularly used antibiotics are resistant in a ICU setup. Look at the ciprofloxacins. It is almost 80 to 90% of the cases ciprofloxacin is resistance. So when we are using the antibiotic in setup of the sepsis and septic shock in ICU and even in the non-ICU, daily assessment for de-exudation is a must. And looking at the clinical improvement, shock resolutions, decrease in the vasopressor requirements, etc., must be looked in every day, and frequently we should look into this. And evidence of infection resolutions also should be searched. For culture positive to the culture negative, so culture should be repeated, and we should measure the procalcitonin. If it is initially found positive, the increase in amount, then it can act as a marker for the resolution of the infections. Procalcitonin level can be used to support the shortening the duration of the antimicrobial therapy. So assessing the procalcitonin from an appropriate lab is very much important. The beta-D glucacan and galactomannan for invasive fungal infection. This is not done in our setup. So source of infection control is another vital factor in reducing the duration of treating with antibiotic and making the patient cured from the sepsis is very much vital. Specific anatomic diagnosis of infection is requiring emergent source control like the empyema gallbladder, septic arthritis, emphysematous pyelonephritis, liver abscess, infected wound. And prompt removal of the intravascular access devices that are a possible source of sepsis or septic shock. Sometimes we used to put the IV channel or the central cannula in central IV line for days together, even after discharge from the ICU or So this might act as a source of infections or sepsis in certain patients. This patient has got admitted under me in Popular Diagnostic Center, Popular Hospital. He is the father of one of my good friend who is staying in England. He has got admitted under me for some disorientations. Initially, I have failed to find what is the cause of the disorientations. After 1 or 2 days of his admissions, I have found the blood count is very high. Then I was searching for localizing the source of infections. I have done everything and left no stone unturned. But just I have found one of the evidences the patient has got the cholecystitis with cholelithiasis. But I cannot explain all the features only with the cholecystitis. Then I have submitted the patients for CT abdomen with contrast. And then the diagnosis came out with the empyema. Meanwhile, the patient's vitals has been deteriorated and the patient's oxygen saturation has been deteriorated. Patients become unconscious. And I have requested my surgeon colleagues to submit what should be the next plan of actions. They have seen the patients, but denied to go for operations, and because the patient's situation was very bad. And finally, the patient was submitted for intubated and under ventilation. And then I have again requested another colleague of my colleague, surgeon's colleague. And finally, they have taken the decision as the patient was ventilated to operate the patient under ventilator when the patient was ventilated, and they really underwent surgery and removed the empyema gallbladder. And finally, the patient is nowadays, today, the patient is getting out of the ICU and feeling good. So source reduction, the removal of the source of infection is one of the prerequisites for curing the patient in case of sepsis and septic shock. Another important thing is the fluid resuscitation, and this should be started simultaneously, not in a taking time. So starting of the antibiotic and fluid selection and fluid resuscitation, all these things should come simultaneously. And crystalloid is the important fluid, like the lactate Ranger solutions, normal saline, and typically an infusion of the 300 to 500 ml of fluid. And albumin can be considered because sepsis is associated sometimes with huge hypoalbuminemia and causing edema even, and then the resuscitation by fluid is very difficult without giving albumin. And sometimes we need the blood products also. And if you look at this slide, whether the patient is with renal failure or without renal failure, or the patient is associated with pneumonia, whether the patient requires oxygen support or the ventilatory support, does not matter, or the patient is on dialysis. Every patient should have the total 30 ml per kg crystalloid, and this fluid should be administered within first 3 hours. Crystalloid fluid infusion should be completed within the first 3 hours. I have mentioned the 30 ml per kg of the IV fluid. Additional fluids may be given by frequent reassessment. So reassessing frequently for the evidence of the, assessment of the fluid balance. And reassessment should include the heart rate, blood pressure measurements, and ABG assessment, respiratory rate, temperature, urine output, lactate 2 hourly to check the lactate clearance. If we found the lactate is getting down, it means the resuscitation is, is up to the mark, getting the optimum level by fluid replacement. So central venous pressure should be assessed by serial monitoring. Superior vena cava oxygen concentration could be done. Passive leg raise test sometimes essential in this while we are managing a case of shock. Raising the legs can improve the situation. Pulse pressure variations could be measured. Stroke volume variations, bedside serial echocardiography can give substance assessment, and bedside repeated lung ultrasound can also help. Regarding the using of the vasopressor in case of septic shock, there are some guidance also with guidance for the steroid administration. Initiation should be done with norepinephrine and titer up to the 35 to 19 microgram per minute to achieve the mean arterial target level. If the target is achieved, continue the norepinephrine alone or add vasopressin 0.03 units per minute with anticipation of decreasing norepinephrine dose. If the target is not achieved and just poorly responsive to the norepinephrine, then we can add the vasopressin up to 0.03 units per minute to achieve the mean arterial pressure. And if the mean arterial pressure is target, then accordingly we can go for the vasopressin for the withdrawal of the norepinephrine. And if still the mean arterial pressure target not achieved, we can add the norepinephrine up to the 20 to 50 microgram per minute to achieve the mean arterial pressure. And then finally, if it is not achieved, we can add the phenylephrine up to 200 to 300 microgram per minute to achieve the mean arterial pressure. If we look at this slide, the time spent with hypotension is associated with the poor outcome. The more the duration of the hypotension, the more the number of the, the death rate is increased. So both severity and duration of the hypotension are associated with the poor outcome. It sounds to correct the hypotension without any delay. So as early as possible, we should start the fluid management to achieve the mean arterial pressure within the target level. So what is the endpoints of resuscitation, or when we can say the patient is getting better? Return to the normal tissue perfusions. Vital signs returns to normal, mean arterial pressure more than 65 millimeter of mercury, normalization of the rectate, renal, the increase in the urine output, warm capillary refill, respiration is, in terms of respiration, the improvement in the rate and depth of respiration. Improve in the level of the consciousness indicates the patient is getting better. Sepsis survival rate increased by faster hospital actions. If anti-sepsis protocol was not implemented, mortality rose by about almost 4% every hour. So it can be life-saving. So resuscitations. Thank you all. Thank you for patience hearing.
Thank you so much, sir, for this amazing presentation. Now it's time for the question and answer session. I can see many questions on the comment section, but we apologize because we won't be able to answer all of them as the time is short. But we will try to answer as much as possible. So without doing any delay, let me request Dr. Nawsabah Noor Apu to start the question and answer session. Dr. Nawsabah Noor.
Thank you. First, I would like to say thank you from a core of my heart to Professor Titu Miah sir for a nice and elaborative presentation. Personally, I was so excited about the session and I have learned a lot. And I think, like myself, who's the audience present tonight, has learned a lot too with the sir's presentation. So as we can see, there's a number of questions and there's interesting questions in the comment box. So I'm going to take some few questions. So first questions, Dr. Mizan Rahman asked, like sepsis is for sepsis management, but does not fungal or viral sepsis carry any emergency attention?
Yes, here this is mainly dedicated for the bacterial infections, but fungal infections also should be in considerations. This is not mentioned over here, and this is the limitations of the sepsis 6.
Okay, so there's another interesting question come to the comment section that what is chronic sepsis? Dr. Noshin Tabassum asked, what is chronic sepsis? Is it an eligible term in clinical medicine? And when to suspect a case of chronic sepsis?
Probably this topic, so far I have gone. Chronic sepsis is not a very familiar word, especially the topic we have discussed. This is very much an acute medical emergency, but chronic sepsis does not fit here. probably my panelist and my chairperson can give some lights regarding the chronic sepsis. Should it be a good term in the clinical medicine?
So actually, I have also heard this term first time today. So I hope that we will get to know about it more tonight. So, sir, another question I'm taking from Dr. Munadi Al Islam. He asked, like, sir, as almost many ventilator-associated pneumonia is associated with Acinetobacter and it has high resistance, what is the best strategies and infection prevention measures to prevent it?
Definitely, regarding the prevention is the IPC is very much important, and the incidence of getting the cases of the Acinetobacter, especially ventilator-associated pneumonia, is very much prevalent in our country, and this is happening also in all other countries. So, antibiotic stewardship, the protocol of using the antibiotic in different institute, the institution-based antibiotic protocol should be there, which is very much deficient in our country. We can name one or two institutes have a very small, scale of the antibiotic protocol. So we should practice this to get rid of these infections. Inadvertent use of the antibiotics, I have shown in my slide, the ceftriaxone and the ciprofloxacin. What about them? These two antibiotics. This is due to the inadvertent use. So by using empirically, inadvertently, with inadequate doses, and here and there, we are getting the resistance of this organism. So again, I like to say the rational use of the antibiotic should be ensured, and the institutional-based protocol for the antibiotic use must be there.
Okay, thank you so much, sir. So another question from Dr. Sadikur Rahman. He asks, like, is there any role of steroid in septic shock?
Yes, this is sometimes we are using the steroids in case of septic shock, and I have shown in one of my slides as it can be used in associated with the vasopressor. And sometimes we found that septic shock may involve causes the adrenal, hypofunction, acute adrenal insufficiency. Because we have not seen too much slides, we know the inflammatory, the cytokine released, and which is causing the huge inflammatory changes, and there are some huge stress in the body is occurring, which needs the steroid, and the adrenal gland become exhausted. And so using of the steroid along with as a vasopressor sometimes helpful, and also to replenish the the function of the adrenal gland sometimes help in septic shock.
Thank you, sir. Sir, another question, like as you have sir mentioned that fluid resuscitation is one of the major part in the resuscitation process in septic patient. So Dr. Zulfa asked, like, if the patient has a heart failure and he develops sepsis, then how can we start fluid during the first hour?
Yes, but the protocol is same. We have to use the same amount of fluid and over the the duration within the 3 hours, because initially the patient is in shock. So all the patients should start it in the same amount of fluid, but frequent assessing, including the central venous pressure, if possible, by going for the frequent echo, we can assess the real situations. The pressure within the different number of the heart, and then accordingly we can titrate the amount of fluid.
Okay, sir, there's another question, sir, regarding the doctor asked, like, regarding is there any role of imaging, like CT abdomen, in the management of sepsis?
I have described one patient in my presentation,
yes, sir.
which nowadays I'm treating. Definitely, I have failed initially to find out the focus of the infections. Because when we suspect a case of sepsis, we must be attentive or be serious in finding out the source of infection. So when I have failed in my case to find out the etiology of where is the location, then because I was suspecting there is something in the abdomen or ulcer, then I submit the patient. By doing the ultrasonography, we have failed to find the actual picture. Then we have submit the patients for CT abdomen. So sometimes CT abdomen obviously can help to find out the focus. Even in case of not only in this case, it can in the gynecological case, obstetrical case, this can help.
Yes, so that
Imaging
was a
has got a
very
tremendous role.
yes, that is a very interesting case that sir you shared, that the empyema was found and later it being managed with a surgery when the patient was on intubation. That was a very interesting case, and actually as we have learned from you, sir, that we can choose this modality depending on the patient's situation. Like if we have suspicions, then we should go for it. So with this thing, I would like to conclude my question answer session, and I would like to convey my regards to Professor Titu Miah sir once again for wonderful discussions and wonderful comments. So now I am moving to our panel of experts for their comments and regarding the presentation and some valuable opinion. So I would like to start with Professor H M Feroz sir. Sir.
Okay, thank you. First, I thanks the SCP Bangladesh and Bangladesh Society of Medicine to select me as a panelist for this session. I also thanks the presenter for his excellent presentation. He has covered everything very nicely about the sepsis, the modern diagnosis or sepsis, and a definition of the sepsis and how to assess the sepsis patient by using the SOFA score and these Q SOFA scores. Can you hear me, please, Noor?
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir. We can hear you. Yes.
There is an echo in this. There's so much echo. Okay.
ফিরোজ, আপনার ওখানে কি মোবাইল অন করা আছে নাকি? মোবাইলে অফ করে নিয়েন।
Okay, sir. Thank you. Maybe
Yes,
so much
sir, that
echo.
was the source, I think. Yes.
That may be the okay. Okay. I also thanks the presenter for his excellent presentation. Okay. He has covered everything very nicely about the
স্যার আপনার পাশে কোন একটা ট্যাবে ইউটিউব অন করা আছে স্যার, এর জন্যই সাউন্ডটা আসতেছে স্যার।
হ্যাঁ হ্যাঁ।
ওকে।
কম্পিউটারে কোন ট্যাবে
করে নিচ্ছি
স্যার।
স্যার কম্পিউটারে কি কোনো আরেকটা ব্রাউজার ওপেন করা আছে স্যার, যেখানে কোনো প্লে হচ্ছে ভিডিও?
ইউটিউবটা অন করা ছিল।
জি স্যার, ওইটা বোধহয় ক্লোজ করতে হবে স্যার।
ইউটিউবটা ক্লোজ করতে হবে জাস্ট। ওকে, আই উইল।
এখন ঠিক আছে।
ওকে।
না তারপর
ওকে। The speaker has covered everything. So we know this. The sepsis is a very serious complications of the infection. Okay.
Sir, please don't worry about the echo, sir. Please carry on, sir. Sir, okay. Please carry on, sir. Sir, please don't worry about the echo, sir. Sir, thank you.
It is a serious complication of the infection. It is a medical emergency. It's actually... Okay, can I say later on? Just I will try and then...
Sir, carry on, please, sir.
আপনার পাশের রুমে কেউ কি শুনছে কিনা দেখেন তো
স্যারের ব্রাউজারে
ইউটিউব
ব্রাউজারে আরেকটা ট্যাব ওপেন করা আছে স্যার, আমি বুঝতে পারছি প্রবলেমটা। স্যারের উপরের ব্রাউজারে আরেকটা ট্যাব ওপেন করা আছে ইউটিউব।
ফিরোজ, আই ড্র ইউর অ্যাটেনশন, তোমার ইউটিউব খোলা আছে, ওইটাই আমরা শুনতে পাচ্ছি ইকো হিসাবে। তো আমার কাছে মনে হচ্ছে তুমি যদি এখন মানে এটা ঠিক করো।
তাহলে স্যার আমি একটু পরে বলতেছি স্যার, আমি তাহলে একটু পরে বলতেছি যে আপনার
নৌসাবা সেকেন্ড প্যানেলিস্ট জুলহাসকে দিয়ে দাও।
জুলহাস স্যারের পরে আমি বলতেছি, আই উইল ট্রাই।
Okay. So, sorry for the inconvenience. So I will start with the panel's discussion with a very renowned professor in our country, Professor Major Retired Julshash Uddin, sir. Sir.
Okay, thank you very much. Bismillahirrahmanirrahim. Respected chairperson of today's session, Professor Quazi Tarikul Islam, I mean, not only the first governor of Bangladesh chapter ACP, American College of Physicians, and also the past president of Bangladesh Society of Medicine, and principal of Dhaka Medical College and professor of medicine, and ex-secretary general Professor Titu Miah, today's speaker, and along with me, the Professor H M Feroz, senior and learned professor of Shohi Sorardi Medical College, host, moderator, and my dear beloved viewers, Assalamu alaikum. It was an excellent presentation, wonderful presentation. It is expected out of him. I know him very well. My colleague is very generous and I mean upgrading, I think. Thank you very much, Professor Titu Miah. You have explained and you have shown the total subject in such a way with ornamentedly guidelines, tables, and informations. Along with your experience, it was revealed during your presentation. It is really good. I think the physician society, not only physicians, in all domain and discipline of the medical profession will highly be benefited out of this presentation. Especially day-to-day life, this is a common topic, common problem they are being encountered in their daily day-to-day practicing life, and definitely it will enrich their medical skill in the management of such a common condition. I have nothing to add on it. All the sides have been covered, I think. I myself also have been benefited out of these presentations. And one point, the one question asked, and it was thrown to the panelist and the respected chairman regarding the chronicity. Is there any scope of making chronic sepsis? I
Yes,
think
sir.
there is no scope of labeling these sepsis as a chronic one, because by definition it is two or more the persistent hypotension, persistent respiratory problem, and also the mental disturbances, along with subset of not improving with the volume expander and requiring vasopressor. So, and also the mortality rate will be very high if there are causes, especially the infections, the source of infections we know, where are the source of infection, it was mentioned very nicely. Even the 1 hour late of starting the empirical antibiotic, it will increase the mortality rate 5 to 10%. Only 1 hour later by starting the antibiotic. Anyway, I think there is no scope of labeling it as a chronic condition. Further will be, I think, it will be given the disposal by our respected honorable chairman of the session. Then, starting from the bacteremia, the mere presence of bacteria in the blood, then septicemia, the multiplication along with the causing the pathology and involving the immune system, the septicemia. Then it is sepsis. Sepsis means the exaggerated, with the overwhelming infection and the exaggerated response of the body's defense mechanism, giving rise to multi-system, multi-organs, and multiple syndromes we have already seen in the management, present pandemicity, out of present pandemicity, the COVID-19 also. Anyway, the one subset is septic shock there. If it is not could not be managed with the volume expander, then the vasopressor is required there. So I think there is nothing to add on it. And then I want to appreciate the ACP and in collaboration with the Bangladesh Society of Medicine for arranging such sorts of sessions on acute medicine time to time to gear up the knowledge and to increase the management skill amongst the all dominant disciplines of the physicians in the medical profession. Thank you very much. Thank you all.
Thank you so much, sir, for your beautiful comment. And I'm echoing with the sir's comment that we all appreciate the effort of the ACP on the management of these regular classes, which will actually help us from the young physician like us to upgrade their knowledge. And I would like to I would like to echo another comment of sir that the presentation tonight was well comprehensively covered. That is actually helped to enrich our knowledge once again regarding the sepsis. Thank you so much, sir. So now I'm moving to another panel of expert who is present here tonight, Professor H M Feroz, sir. Sir, you have to unmute yourself, sir. Mic to unmute korte hobe, sir.
Okay, thank you. I am sorry for technical problem I face, and also it disturbed you. First of all, I would like to thanks to SCP Bangladesh chapter, Society of Medicine, organizing such a very valuable session. And I also thanks the presenter for his excellent presentation. He had covered everything regarding the sepsis, sepsis management and assessment of the sepsis. Now, sepsis, very serious complication of the infection. It is a medical emergency. Terminology time to time অনেক চেঞ্জ হয়ে গেছে আমার যেটা মনে হয় যে নিউয়ার যে টার্মসগুলো এখন সেপসিস সম্বন্ধে এবং সেপটিক শক সম্বন্ধে এসেছে এর আগেও কিছুদিন আগেও কিন্তু এরকম ছিল না অনেকটাই চেঞ্জ হয়েছে সো এই আমরা এসিপি বা শুধু মেডিসিন এক্সপার্ট যারা আছি আমাদের সেপটিস সম্বন্ধে আমরা যতটুকু জানি বা আজকে জানলাম আরো অনেক কিছুই আমার মনে হয় সেপসিস it should be the concern of all the healthcare staff because the sepsis এবং septic shock may occur in any setting, any emergency department, in medicine ward, gynae ward, surgical ward. So all the healthcare provider should be very much aware of this sepsis. The early diagnosis of the sepsis, as the speaker says, can save the life. Every 1 hour delay increase the mortality. He speak very nicely about this. I have nothing to comment about that. Only few comments because where the patient of the sepsis and septic shock should be treated, I think জিনিসটা একটু ক্লিয়ার করলে বা আরেকটু বললে ভালো হতো। It is my suggestion that this patient ideally should be treated in high dependency unit or CCU, but we should not wait for that. We should start the treatment anywhere, even at the emergency department, because every delay will increase the mortality. And the cornerstone of treatment, as the speaker, Professor Titu, has very nicely said, it is the antibiotics and the organ support, including the vasopressors, fluid replacements, other so on. Very nicely he has explained everything elaborately. I have nothing to tell about this. One thing I want to emphasize is that how to diagnose early, because the blood culture may not be available everywhere. Even in our country, we cannot do the blood culture so quickly. So even before getting the blood culture report, we have to start the antibiotic, as you told. But I think there may be some delay if you wait for the blood culture report. Before that, we have to start the antibiotic, already told. Is there any other method we can use? For example, we can use the PCR to identification of the infection early, because it will give the result very much quickly. Another thing, if I can ask the, I should ask the presenter, I have some confusion about this cytokine storm and immunosuppression. I think the cytokine storm it more occurs in the COVID condition, and immunosuppression may occur in the sepsis. Maybe may I request the presenter to clear this point. And other thing, very nicely, the presenter has talked about this. I have nothing to comment about this. So I thanks the organizer. Again, thanks the presenter and our teacher, Professor Quazi Tarikul Islam, to select me as a panelist. Thank you. Thank you all.
Thank you, sir, for your valuable opinion. Sir, Titu Miah sir, আপনি কি কিছু বলতে চান? স্যার যে কোয়েশ্চেনটা বললেন যে
Thank you. Yes, sir. But the two things has been addressed by sir. One is the where the patient should be managed. This is one. This could be in the initial stage outside the ICU or SDU. We can diagnose and we can manage the patients even in case ward if we can diagnose earlier, and the right place where all the facilities of fluid resuscitation, monitoring, like the high dependency unit, including the ICU, is another important. Regarding the cytokine storm, we are very much encountered with the cytokine storm in case of COVID-19. But
yes.
the thing is the what we have learned in the previously, which is very much popularly known, the SIRS, systemic inflammatory response syndrome. It's very much associated with sepsis. So this is one of the variety, one of the pattern of the cytokine storm. So cytokine storm is always there in case of sepsis, where there is sepsis, but it is not always present in case of COVID-19. So COVID-19 may be without cytokine storm. So, but when there is severe, COVID-19 is there associated with some sorts of immunosuppression, maybe due to treatment, maybe due to the disease process. Of course, some sorts of immunosuppression may be in case of severe sepsis, where the total blood count may be, usually we found the high blood count, neutrophilic leukocytosis, but when it is the burden of the organism is very high, sometimes may be associated with the neutropenia even. So neutropenic sepsis is there. So though they have mentioned in some literature, immunosuppression is very much predominant in case of COVID-19. But there still the area is blurred. Thank you.
Thank you, Professor Titu Miah, for your nice answer.
Thank you, sir, once again for the clarification of the idea between the cytokine storm and the concept of immunosuppression. So I'm thankful to Titu sir once again for his wonderful presentation, and he was my direct teacher. So now I am moving to our chairperson tonight. He was also my teacher, and I feel very glad tonight to be present here as a moderator. So, sir, now I would like to welcome Professor Qazi Tarikul Islam, sir, to share his valuable opinion regarding the presentation, and with his comments and opinion, we are going to conclude the session tonight. Thank you all for patient hearing and with us being present here. Sir.
Thank you very much, Dr. Nawsabah, and no doubt the moderation was very good. First of all, I beg pardon because initial few minutes when Professor Titu started, I was not available in person. I was connected, but unfortunately, the emergency meeting of the National Technical Committee regarding obviously related to opening the medical college. The government is trying to open the medical college from 21st of August. So there were debate in favor and against. Truly, the National Technical Committee currently undergraduate teaching associated person was only me. So a lot of questions were coming to me, what to do, how this can be done in final year, a non-COVID ward, how they will go with full PP or not, something like that. So I beg pardon, as well as I want to, because Principal Dhaka Medical College, Titu Miah, should know that get ready that from 21st of August, possibly you are going to take the final year and second year student. Because first prof and coming that means the next final prof examinee, one batch is appearing, the other one they are junior to those batch. However, actually I was with 2 earphone in the 2 year. From one hemisphere I was listening to those people and obviously I did not miss Titu's lecture. It was brilliant, no doubt, because in a very comprehensive way, I can remember when I gave one lecture in Dhaka Medical College after my retirement, maybe pre-COVID sometime. I had 104 slides, but T2 had, I think, 60 to 65 slides. He completed everything because we have to remember today's program was on emergencies in sepsis, sepsis management emergency. That is why he could manage the emergency part only. But beside this, like bundle approach, 3 bundle, 6 bundle, so many things has to be discussed. But I think to the point, it was excellent. And obviously, a question came, what is chronic sepsis? So far I can remember, usually this term we do not use, but chronic sepsis, it is not a disease. Rather, this is the accumulation of some condition, like renal failure, like associated some other opportunistic bacterial infection, if that can occur repeatedly in an immunocompromised patient, that can produce chronic sepsis. So this term is not well delineated and well practiced by the clinician. Obviously, Professor Titu mentioned the red flag sign of the sepsis. Without red flag sign, you cannot exactly label where the patient is and what to do next. So it was excellent, step by step. Whenever you will talk to sepsis, the question of antimicrobial resistance will come out, and which is a worst issue in our country. There is the antibiotic is available over the counter, and every people during this COVID, they are getting either the doxycycline or azithromycin or combination of amoxicillin with clavulanic acid, they are taken by themselves. So these drugs is nowhere in the platform. So if you go to the ICU, I do not go to the ICU for the last 1 year, but before that, ICU was a regular visiting place for me because any of my patients or to see other referral cases, really it was so disappointing what Titu mentioned in his slide, that no doubt that everything in our ICU setup in comparison to the other parts of the world, if you consider we are also in a very bad shape now. If somebody is infected with Acinetobacter, there is a proverb, this patient will not recover, so write down the death certificate in advance. Don't take it as a remark. Rather, this is a proverb, because this patient will not get back from the situation. So that is why some of the bacteria, they are the permanent inhabitant, that is Acinetobacter, Klebsiella, Pseudomonas, and what not antibiotic is being used in the ICU. What Titu told, polymyxin, colistin, they are using more than that. They are using tegacycline. They are using the 4th generation of many other, and these are all in combination. So truly, মানে আমি এখন একটু মনের কথা বাংলাই বলি, আসলে আমরা যাচ্ছি কোথায়? আমরা নিজেদেরকে যদি আজকে এসিপি যে এই টপিকটা চুজ করেছে, এর পিছনে তো একটা ডেফিনেটলি কনসেপ্ট আছে। সেপসিসকে দিয়ে আমরা অ্যান্টিমাইক্রোবিয়াল ইউজকে যেন অ্যাপ্রোপ্রিয়েট করতে পারি, আমরা যেন যথাইচ্ছা ব্যবহার না করি। সো সেই কারণে আমি বলবো চয়েস অফ দিস টপিক ইজ সুপার, বাট আমরা যদি এখান থেকে আজকে কোনো কিছু না নিয়ে যেতে পারি, নলেজ, তাহলে আমার মনে হয় কোনো লাভ হবে বলে মনে হয় না। আমরা যে তিমিরে সেই তিমিরেই পড়ে থাকবো। আমি অবশ্যই টিটু উত্তর দিয়ে দিয়েছে যে নিউট্রোপেনিক সেপসিসে অবশ্যই সবকিছু তখন কিন্তু শাটডাউন হয়ে যায়, তখন আর তার ইমিউন রেসপন্স করার ক্ষমতা থাকে না। সেই জন্য বলা হয় নিউট্রোপেনিক সেপসিস ইজ ডেঞ্জারাস। এবং যদি ডাক্তার বোকা হয় তাহলে সে ভাববে টোটাল কাউন্ট তো 3000 আছে, তাহলে আর সমস্যা কি, 2000 আছে। আরে 2000 থাকা মানেই বডি ইজ নট রেসপন্ডিং টু দি fighting against the organism, so that is much more dangerous. অবশ্যই আজকে দুজন আমাদের যে প্যানেলিস্ট, তারা অবশ্যই চমৎকার কন্ট্রিবিউশন করেছেন। আই মাস্ট অ্যাপ্রিশিয়েট দেম। অ্যান্ড কথা বলার তো অপেক্ষা রাখে না যে এমার্জেন্সি ইস্যুজ ইন সেপসিস ইটসেলফ ইজ অ্যান এমার্জেন্সি, নো ডাউট। তার মধ্যেও যখন আমরা যুদ্ধ করতে হবে পেশেন্টকে বাঁচানোর জন্য, তখন আমাকে অ্যান্টিবায়োটিকের চয়েসটা, এটা হবে স্টুয়ার্ডশিপ, যেটা এটা হবে নাম্বার 1। এবং আমার ওই যখন শকে আছে ওইখান থেকে বান্ডেল অ্যাপ্রোচে যে আমি তাড়াতাড়ি করে রিসাসিটেট করবে, এমএপি দেখাচ্ছিল। আমি জানি না আমাদের অনেক ছাত্ররা হয়তো আছেন, মিন আর্টেরিয়াল প্রেশার আপনারা জানেন হয়তো, আমি তারপরও আমি মাস্টার তো একটু হয়তো এই জন্য বেশি বকছি। মিন আর্টেরিয়াল প্রেশার মানে হচ্ছে সিস্টোলিক প্লাস ডাবল অফ ডায়াস্টোলিক ডিভাইডেড বাই 3। এখন ও বলছে 65-র উপরে থাকতে হবে, তার মানে 365 হচ্ছে 180 আর 15 195। এখন আপনি ধরেন 120/80 যদি হয় তাহলে 200, তাহলে তো আপনার পেশেন্ট ভালো। এমএপি 65 করতে যাওয়া মানেই হচ্ছে পেশেন্ট অটোমেটিক্যালি দি ব্লাড প্রেশার উইল কাম আপ অ্যান্ড দি পেশেন্ট উইল ইমপ্রুভ। যে কারণে আমরা মেন আর্টারিয়াল প্রেশারের এই প্র্যাকটিসটা করি না। আমরা সিস্টল ডায়াস্টল দেখে খুশি হয়ে যাই, পেরিফেরি দেখি। যেমন ধরেন ডেঙ্গু শকের বেলায় আমরা ক্যাপিলারি রিফিলিং টাইম দেখি, বিকজ এখানে তো মানে সিভিয়ার ভাস্কুলার লিকেজ হয়, ভাসোডাইলেটেশন হয়, এবং অবশ্যই যত সাইটোকাইন রিলিজ হয় সেপসিসে, লট অফ সাইটোকাইন, that this causes very serious type of vasodilation and fall of blood pressure. That is why I am sure that this was very helpful to everybody. আমি যে গল্পটা বলতে চাচ্ছিলাম, it was a very bad story. আমি যে কারণে ইউরিনারি সেপসিস দেখলে, ইউরোসেপসিস দেখলে আমি খুব ভয় পাই বলতে পেশেন্টকে টু মাচ অ্যাটেনশন দেই। আপনাদের কাছে এটা কতটুকু মানে আবেদন রাখবে আমি জানি না। আই লস্ট ওয়ান অফ মাই ট্রেনি এই 2010 সালে। শি ওয়াজ ডক্টর রেহানা। আমার মনে হয় টিটুর মনে আছে যে আমরা পরে আই ওয়াজ আউটসাইড কান্ট্রি, আমি আমেরিকা ছিলাম। আমেরিকা থেকে ফিরে শুনি যে সে ইউরিনারি ট্র্যাক্ট, তার নতুন বিয়ে হয়েছে, ইউরিনারি ট্র্যাক্ট ইনফেকশন নিয়ে সে এই কোট্রামাক্সাজল আর সামথিং এসিপ্রোফ্লক্সাসিন এগুলো নিয়ে ভর্তি আছে কোন একটা ক্লিনিকে। তো ওয়ার্ডে আসলে যা হয়, অনেকদিন পরে বাইরে থেকে আসছি, সব ডাক্তাররা অনিয়ম যাই করুক ওই দিনকে সবাই হাজির। কিন্তু আমি যখন ডক্টর রেহানাকে দেখছি না, বলছি যে আমার তো মনে হচ্ছে একজন বা দুজন নাই। বলছে স্যার রেহানা খুব অসুস্থ। কি অসুস্থ? স্যার ইউটিআই হয়েছে, একটা ক্লিনিকে ভর্তি আছে। তো আলটিমেটলি আই ওয়েন্ট টু দ্যাট ক্লিনিক টু সি হার ইন ঢাকা মেডিকেল কলেজ থেকে ব্যাক করার সময়। যে দেখি তার সারা শরীরে অলরেডি র্যাশ, প্যালপেবল র্যাশ, থ্রম্বোসাইট কাউন্ট, কনজামটিভ কোয়াগুলোপ্যাথি শুরু হয়ে গেছে। এবং থ্রম্বোসাইট কাউন্ট আমার এক্স্যাক্টলি এই মুহূর্তে মনে নাই, 10-11 বছর আগের কথা, তো ভেরি লো। আমি পরের দিন সকালেই তাকে নিয়ে ক্যাবিনে ভর্তি করলাম এবং আমরা সব ডিপার্টমেন্টালে, মানে আমাদের ইউনিট হেড যারা ছিল, আমরা 5 জনই বসে, এবং টিটুরাও ছিল শিওর, আমার যতদূর মনে পড়ছে, ওই মেক এ মেডিকেল বোর্ড। এবং আমরা তাকে ওই সময় পাইপারাসিলিন টাজোবেক্টাম আমরা যে দিলাম, তাতে মনে করলাম 10 বছর আগে যে আমরা বিশাল একটা ডিসিশন নিয়েছি, যেখানে এখন মানে অ্যান্টিবায়োটিক লিখতে কারো হাতও কাঁপে না। সেকেন্ড ডে, থার্ড ডে পেশেন্ট ইমপ্রুভ। বাট তার যে হাজবেন্ড, হি ওয়াজ এ বিজনেসম্যান। সো ও বলল যে আমি আমার ওয়াইফকে সিঙ্গাপুর নিয়ে যাব। সিঙ্গাপুর নিয়ে গেল, শি ডায়েড দেয়ার। কিন্তু ওর ডায়াগনোসিস হয়েছে, আমরা তো 5 বার ব্লাড কালচার করেছি, বাট উই কুড নট, আমাদের যেহেতু রেফারেন্স ল্যাবরেটরি নাই, আমাদের কনভেনশনাল কালচার, তাও সেই কালচারের উপরে রিলাই করবেন কি করবেন না নিজেরা চিন্তা করে দেখবেন। আলটিমেটলি ও ওখানে মারা গেল, ডেড বডি নিয়ে আসলো। ছেলেটা আমার সঙ্গে দেখা করলো, বললো স্যার আমি খুবই কৃতজ্ঞ, আমি নিয়ে গেছিলাম কিন্তু আমি ওখানে যেও বাঁচাতে পারিনি। আমি বললাম যে আপনি ওখানে গিয়ে কি ডায়াগনোসিস? বলছে আপনারা যা বলছেন তাই, কিন্তু ওখানে গিয়া ব্যাকটেরিয়াটা ধরা পড়ছে, আমি তো বিজনেসম্যান, আমি বুঝি না, বলে কাগজগুলো আমার সামনে দিল। তখন আমি দেখি, উড ইউ বিলিভ, ই কলাই সেপ্টিসেমিয়া। ই কলাই তো কমেন্সাল সামটাইমস, বাট এটা যখন প্যাথোগনমিক হয়ে সেপসিস হয়, সেপ্টিসেমিয়া হয়, এবং সেপ্টিসেমিয়া সেপসিস হয়, তখন আলটিমেটলি কিন্তু সঠিক চিকিৎসা দিতে দেরি করলে আপনি যতই চেষ্টা করেন, ইউ মে নট বি এবল টু ব্রিং এনি লাইফ ব্যাক। আমার এই গল্পটা শোনার জন্য আমি সবাইকে ধন্যবাদ জানাচ্ছি। ইউরোসেপসিসকে কখনো ছোট করে দেখবেন না। যা প্রেসক্রিপশন দেন না কেন, কালচার করে বলবেন যে খবরদার অ্যান্টিবায়োটিক খাবেন না, আগে ইউরিন কালচার দেন, ইউরিন কালচার দিয়ে অ্যাপ্রোপ্রিয়েট অ্যান্টিবায়োটিক দেন। আই থিঙ্ক দিস ইজ দ্য লাস্ট ওয়ার্ড। আর তাছাড়া ম্যাক্সিমাম অল নলেজেবল টক্স that has been delivered by Professor Titu Miah and our 2 panelists. Thank you very much. Thanks everybody যারা শুনছেন সবাইকে, এবং অর্গানাইজারকে আমাকে এখানে চেয়ার করার জন্য সুযোগ দিতে। থ্যাংক ইউ। আমরা এখানেই ক্লোজ করছি। এরকম আরো একটি অনুষ্ঠানে নিশ্চয় আবার কারোর সাথে দেখা হবে। ধন্যবাদ সবাইকে।
Sadly, we have come to the end of today's program. We have learned so many essential things about the management of sepsis from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator Apu for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very interesting answers. If you couldn't see the whole program or joined late, there is no need to be worried. You can find the whole program on our YouTube channel right after the live session finishes. Our next health talk on acute medicine will held on 17th of August, where Professor Khan Abul Kalam Azad sir will discuss on the topic gastrointestinal bleeding. So, see you all in the next episode. Until then, take care.